Hi, welcome to Mastering Anesthesia. If you've clicked on this video, then you're probably here to learn about burn. And you're in the right place. In this video, we're going to talk about the types and classification of burn, pathology of burn, physiologic consequences, management, and primary anesthetic and ICU management. So let's go. Burn can pose a very significant mortality and morbidity, whether it is acute or long-term, and it is therefore imperative for us to be able to detect a major burn. A burn is considered a major burn if it involves the IV fluid for its management, and this can be 10% in child or 15% in adult, according to the total body surface area, and or burn involves the airway. Detecting this will alert us to start the management early and aggressively. Here is the cross-section of the skin. You have the epidermis, the dermis, and the hypodermis. Burn is categorized into different severity according to the depth of burn involved. It can generally be divided into partial or full thickness burn, and in partial it can be either first degree or second degree. This depends if it crosses the basement membrane. If it crosses beyond the epidermis into the dermis, then it has become a second degree burn. Meanwhile, the full thickness burn, also known as a third degree burn, involves all the skin layers, and in this case, the skin will be pale, bloodless, and insensitive to the firm touch of a sterile needle. This is different from first and second degree burn, where the sensation is usually intact and healing of the skin is more likely to happen. Mechanism of burn refers to how you get the burn injury in the first place. It can be from a contact with a direct hot surface, it can be from a scald, from fluid or gas, which usually will be a superficial burn. You can get a flash from a brief burn causing a partial thickness burn. You can get from flame, normally this will be full thickness burn, and there will be a different type of burn altogether, like chemical and electrical burn. Next, let's talk about how burn actually causes its devastating complications. So, the burn pathology can be viewed from two different angles, one occurring from this local perspective and one from its systemic effects. Now, when a burn happens at a local site, there will be leaky capillaries happening over there. Okay, so edema will ensue, and if it happens to the airway, it will cause obstruction. Chest wall, it can cause difficulty in ventilation. If it happens at the limbs, it can cause ischemia. And this typically will go on for about 3 to 36 hours. Systemically, when burn injury has caused damage to tissues, there will be release of middle molecules or inflammatory mediators. This include leukotrienes, prostaglandins, oxygen-free radicals, and histamines. And this will cause generalized capillary permeability to increase and general vasodilation, reduction of systemic vascular resistance. The cumulative effect will cause a general hypovolemia, increasing the hematocrit and reduction in tissue perfusion. This is called the burn shock, and what it does, it will reduce the urine output. And when it does, the patient will get restless, disoriented, and loss of consciousness ensues. Owing to the pathology of burn management can be divided into two phases according to the cardiovascular status. The low cardiac output phase, or ebb, known as the resuscitative phase, and the high cardiac output phase, or the recovery phase, known as flow. The ebb phase normally occurs for about 48 hours, and it involves reduction in cardiac output of about 60%. And this happened due to hypovolemia, reduction in response to catecholamines, increase in systemic vascular resistance due to increase in vasopressin levels, and reduction in myocardial contractility. The flow phase occurs about 72 to 96 hours in post-burn, and is characterized by hyperdynamic and hypermetabolic response, characterized by increase in cardiac output, tachycardia, increasing in myocardial oxygen consumption, reduction in systemic vascular resistance, and all this is owing to the elevation of catecholamines in major burns. So to combat these effects, an unselective beta blocker can be used to minimize this catastrophic effect. And in the ebb phase, fluid resuscitation is key. And the effective resuscitation is gauged upon the American Burn Association guideline, which we want to aim of urine output of 0.5 to 1 mils per kilogram. This would be our resuscitation endpoint. A lot of physiological changes happen after getting a burn injury, and we're going to explore a little bit about that in different systems. For the central nervous system, the patient will undergo severe pain at rest and with dressing change can be due to stimulation of the skin nociceptors, the mechanical distortion of mechanoreceptors, and also the release of endogenous noxious chemicals. Meanwhile, the direct electrical burn damage to the central nervous system caused by electrical burn can be transmitted along the blood along the high vascular center, especially the brain and the spinal cord. So what happens, there will be activation of simultaneous voltage gated channels causing widespread activation. So there can be seizure and coma. Whereas the psychological and behavior changes due to severe burns include PTSD and also those who have underlying depression, anxiety, other things can become worsened after the burn injury. As for the respiratory system, which is very, very important for us anesthetists, we have to understand that there are different changes that can happen. Ventilation will be impaired due to the reduced respiratory effort. If the GCS of the patient drops, lung expansion can also be reduced as the result of restrictive effect from the burn, whether circumferential or non-circumferential. Air entry is reduced if there is airway edema. Lung compliance can also be compromised if there is pulmonary thermal injury, and ARDS can also follow suit after burn injury. Diffusion of gas will be impaired if there is accumulation of fluid in the lung from pulmonary edema and thermal injury. Shunt fraction will also increase due to ventilation perfusion mismatch. This can be due to collapse of lung, reduction in airway flow due to airway swelling, increase in sputum retention, increase in risk of pneumonia, and finally, impaired oxygen transport and mitochondrial metabolism. This can be due to the direct effect of carbon monoxide poisoning and cyanide poisoning. As for the circulatory and cardiovascular consequences of burn, can be divided into the early phase and the late phase, like mentioned before. The ebb phase is the early phase, where it is associated with generalized leaky capillaries, where the fluid from the intravascular leaks out, causing hypovolemia, and the late phase is due to catecholamine surge, causing hyperdynamic circulation, increased cardiac output. Regional changes refer to the formation of a scar at distal limbs or the chest, which causes limb compartment syndrome, where a scar formation essentially works as a tourniquet. Compound that with the local edema at the site will impair blood flow to the distal sides of the limb, causing ischemia and essentially might require amputation later. Other physiologic consequences worthy of note include electrolyte imbalance, where the exudates are rich with electrolytes. So, naturally, electrolytes will go out from the intravascular. So, there will be hyponatremia, hypochloremia, calcium will be low, phosphorus will be low, even potassium will be low. But the notorious hyperkalemia and burn can be due to other reasons, such as tissue injury and hemolysis. And we all remember as anesthetists that succinylcholine is contraindicated in burn because of the risk of hyperkalemia, and this is due to the presence of extrajunctional nicotinic acetylcholine receptors. Next is the renal impairment related to burns. This can be due to multiple factors, including hypovolemic shock state, sepsis, rhabdomyolysis, abdominal compartment syndrome due to the circumferential torso burns, and also massive hemolysis causing hemoglobinuria, overwhelming the kidneys, causing kidney injury and acute tubular necrosis. Remember that renal impairment does affect mortality in the patient. Then the patient can also have impaired thermoregulation because loss of skin. Skin is essential in regulating the body's temperature, hypermetabolic state, and stress-related hormonal changes. So there'll be changes in cortisol, T4, growth hormones. These are all altered during burn injury and after the burn. Next, let's move on to the actual management. I like to bring attention to three different aspects of the management. First being the first aid and primary management. Next is the burn management itself in terms of its dressing, the surgery, and the anesthetic consideration. And lastly, it's the systemic management according to the systems. So as for the first aid of burn management, if you do come across a patient with burn injury, first thing that you like to do is remove the casualty from further injury. You like to extinguish the flames if you have the means to do so. Remove the clothing that can potentially burn the skin further. Turn off any electrical source and douse the flame in water. Lie the patient down as flame goes up, so you would like to minimize the spread. And cover the wound, yeah? Avoid the patient from getting cold and give oxygen during transport to the hospital. Next comes the primary management. Always go back to ABC, the airway, the breathing, and the circulation. Now, airway, if there is a suspect of cervical injury, please stabilize it. Intubate if there is a suspicion of airway burn. This can be suggested by reduction of GCS of 8 and less, facial burns, singeing of facial or nasal hairs, oropharyngeal carbon deposits, carbonaceous sputum, hoarseness of voice, stridor, wheezing, and burn with a total body surface area of more than 30%, and carbon monoxide in the blood more than 10%. And anticipate difficult back mass ventilation due to pain, and also contraction. Laryngoscopy may be also difficult due to the presence of contraction of the face. LMA may not be helpful if there is edema of the airway down distal to the LMA insertion, and also if there is a chance awake intubation is always preferred. For breathing, the problem that we may face is the inhalational injury. This will cause lung damage, and the consequences include ARDS, carbon monoxide poisoning from substance released from the flame, cyanide poisoning from also burned substances, and also chemical irritants that is released from the substances that are burned. So this can cause bronchospasm and specific system toxicity. Once the airway and breathing has been secured, circulation needs to be tackled immediately afterwards. So fluid resuscitation is key to saving the patient's life. So according to the percentage of body surface area, we can rapidly calculate the area involved with the use of rule of 9. This is a very rapid method for you to estimate the percentage of burn. And if you want to go even higher in accuracy, you can use Lund and Browder. For the rule of 9, it can be depicted as such. You have the head, the neck, the torso, where the head contributes to 9% of total body surface area, the front of the torso 18, the back 18, right arm 9, left upper limb 9, right lower limb 18, left lower limb 18, and the perineum is 1%. For infants, the numbers are a little bit different. It's larger compared to adults because of the relatively larger body surface area per body size. So the head will contribute to 11%, the right upper limb 11% instead of 9, the left upper limb is 11, right lower limb is 22%, left lower limb is 22%, the front of the torso is 22%, the entirety of the back torso is 22%, and the perineum consists of 1%. So how much fluids do we have to give? Conveniently, we have Parkland's formula where it describes the crystalloid resuscitation with Hartmann. So it gives a total of 24-hour fluid requirement, wherein the formula is 4 times percentage of body surface area times weight in kilogram. So you give half of the total over the first 8 hours and the remainder over the next 16 hours. Some caveats pertinent to our resuscitation is that when there is involvement in inhalational injury, fluid requirements can increase by about 50%. Regular assessment is crucial during our resuscitation. Blood pressure, heart rate, capillary fill time, urine output, GCS, hematocrit are all needs to be monitored. And if our assessment deems inadequate, more fluid should be given. Next management is the management of the burn site itself, where it requires dressing and surgery. So we are dressing because we want to reduce infection, absorb and exudate, and you need to use bactericidal agents such as sulfur, sulfadiazine, and silver nitrate. Antibiotics are generally avoided because this can confer resistance. Circumferential burns require immediate attention because if torso is involved, breathing and ventilation is compromised, and if limb is involved, limb ischemia will definitely happen. And all burns need to be excised within 48 hours. And during the procedure, blood loss can be massive, and graft also may be needed during the operation to close the burn site. So for the anesthetic considerations, primarily the airway is of concern. There will be painful back mass ventilation. Fibrosis and contracture will cause a limited range of motion of the neck. ETT secure can be more difficult. Edema around the ETT can be a challenge for us to extubate the patient. As for muscle relaxant, succinylcholine, a depolarizing muscle relaxant, can cause hyperkalemia. This can go on after 24 hours up to 18 months. It's generally avoided, only considered if the benefit far outweighs the risk. As for the ventilation, IPPV is generally more preferred than spontaneous ventilation. Increase in metabolic rate causes increase in oxygen consumption. PQ mismatch increases shunt fraction. So all of this requires us to increase the FiO2 and PEEP. As for circulation, we need to be prepared for any catastrophic collapse of the circulatory system. There will be excessive blood loss during excision of eschars. Secure large bore burner for easy resuscitation. Group cross-match adequate blood products. Be prepared for inflammatory response intraoperatively, where there can be surge of inflammatory mediators. So if hypotension ensues, fluid would be the best option for us to resuscitate, blood if deemed necessary, and the use of noradrenaline may impair circulation to grafts, which is generally not liked by plastic surgeons. Temperature should be monitored because heat loss is inevitable. The greater the heat loss, the greater the physiologic consequences of hypothermia. So this can be due to the vibration of burn area and also inability of the vessels to vasoconstrict. And following major changes occurring in different systems following burn injury, there will be altered pharmacokinetics. Our volumetric distribution will increase for water-soluble drugs, increased in extracellular fluid to intracellular fluid ratio. Albumin will be lost in the exudates, causing reduced protein binding. Metabolic rate will increase in temperature. All of this will alter the half-life of many drugs. We have seen how burn injury can inflict damage to the lung. So, in pulmonary management, we are dealing with the intoxication or hypoxemia, respiratory tract injury due to the irritants, and thermal damage. Burn patients are very likely to get carbon monoxide poisoning. The affinity of carbon monoxide to hemoglobin is way greater than oxygen. So, when that happens, anoxia may cause headache, nausea, coma, convulsion, even death. 100% of oxygen helps by reducing the half-life of carbon monoxide from 4 hours to 80 minutes. Hyperbaric oxygen can also help in this case. Other intoxication materials include hydrogen sulfide, cyanide, and chloride. The irritant that we might not be aware of is soot, where if such thing is there, we can give NAP 1.8% of sodium bicarb. And other irritants include chlorine, ammonia, and phosgene. Direct injury from heat causes thermal damage. This is due to hot gas or flame. So the management include oxygen therapy, mechanical ventilation, physiotherapy, tracheobronchial toileting, and increasing the fluid requirement. So if the patient develops ARDS, it should be treated accordingly. Remember that renal failure is one of the complications of burn. It is due to hyperperfusion, septicemia, or hemoglobinuria. So alkalization of urine can be of help. Early dialysis will help remove the toxins that can damage the kidneys. And remember that renal failure associated with burn has high morbidity and mortality. Hematological wise, patient can bleed during operation. there'll be plenty of exudates, there'll be intravascular hemolysis, so blood transfusion might be required. Nutrition or GIT, remember that patient will be in a profound catabolic state, so they require early and aggressive enteral feeding preferably to maintain the intestinal mucosal integrity and for wound healing. So glutamine is advisable to be administered into the preparation, and also PPI will reduce in the incidence of stress ulcer. As for the central nervous system, the patient is prone to have hyponatremia causing burn and capillopathy, so this can be avoided by aggressively treating the hyponatremia. Next is sepsis, which is a major cause of death. So in early can be contributed by Streptococcus and Staphylococcus. Late phase can be due to Pseudomonas acinetobacter and fungi. Avoid giving prophylactic antibiotic, which is not recommended. Instead, take regular cultures if necessary and treat accordingly. Thank you for watching my video. I hope my video has helped you even a little bit. If you like more contents like this, please hit the subscribe button and comment and like down below. See you in my next video.